Good morning, everyone. I am Mr. Abhay Patan, Assistant Professor, Royal Institute of Nursing. Today we have an eminent personality, Dr. Leena Casey, Dean, Ennapoya Nursing College, Ennapoya University, Bangalore, Karnataka. Madam has completed BSc Nursing, Government College of Nursing, Bangalore. And Madam also completed MSc Nursing, Community Health Nursing in Father Mudar College of Nursing, Bangalore. Uh, Madam is awarded a PhD program in 2015, Rajiv Gandhi University of Health Sciences, Bangalore. Madam is also having more than 20 years of experience in nursing profession. At present, Madam also published many national and international publications, and Madam also honored awards like Master Trainer in GFATM HIV Training Project Appreciation, Master Trainer in Emergency Nursing Life Support. Madam also life member of Indian Nursing Council, Society of Community Health Nurses of India, Sochini, Nursing Research Society of India, Trained Nurses Association of India, and Madam also organized many national and international workshops, conference. So today we have presently Madam is working as a Dean in the Ennapoya Nursing College. So now I'm over to Madam.
Thank you, Abhay, for the introduction. Once again, welcome you all to this session on autonomy in community health nursing. So just to have an overview of what is autonomy, and then quickly we will move on to what is autonomy in community health nursing and how it is relevant to a setup like India. So we know autonomy is all about making decisions. It is to dare to do something. When we say we want autonomy, it means we are taking authority to do things, to make decisions, to manage our own affairs. And then, as you know, autonomy is not to do anything. Autonomy is to work within the framework of your professional practice and based on your professional knowledge. So the very prerequisite to use or to exercise autonomy is to have professional knowledge or professional competency. So without professional competency, it's difficult for us to exercise autonomy and exercise power or to make decisions. And as we understand, it is maybe in this area that we fail. Many times we fail to update our knowledge. We fail to be competent and exercise our powers because we are in doubt about ourselves, our competencies, and whether we are entitled to do this. So this daring nature will help us in improving the professional status of nursing. And it's easy that we complain always, okay, nurses don't have autonomy. But who should give us this autonomy? It is that we ourselves can exercise this autonomy. It's not given by somebody. It is that we have to grab those opportunities and exercise our powers, make decisions, and work for the good of society. So, as I said, increased autonomy is all about increased responsibility and accountability because they go hand in hand. When we say we have increased autonomy or we want increased autonomy is a demand that we hear everywhere. But are we prepared to take up responsibilities, increased responsibilities, more than what we were doing yesterday, more than what our forefathers were doing or senior professionals were doing? So this is where we need to fix the problem. And when we say about increased responsibility, we won't be able to take up increased responsibilities or varied responsibilities when we fail to attain the competencies. So it is also to be prepared to take actions. So are we preparing our young graduates to be competent? If they are competent, that means they have readiness to do the actions where automatically the autonomy will come. With that, increased responsibility will be continued. So this is like a cycle. So where to begin? Maybe as educators and as young professionals and the students, it is for us to break this chain by improving the competencies so that we prepare nurses for better. They take up responsibilities, they have more and more of autonomy, and we can claim to have a very good professional status in the society. So autonomy and nursing, we always complain about lack of autonomy in nursing. But it is an age-old problem because of the gender perspectives of nursing. Maybe from olden times, it is the females who are entering the profession. Of late, there are changes, but the number of men entering the profession is very low even now. And that we are used to paternalistic behavior of other co-workers in the health team. And we know that being the leader of the health team, the medical professional earlier invariably used to be a male person, and they would exercise their powers, and the female would only listen and follow whatever instructions are given. And maybe there was no opportunity to exercise autonomy those days. But we know that the change is happening with different type of people entering the profession, male entering the profession, more of females entering the medical profession, so that again that paternalism part is coming down. Maybe we will see some improvements in the future when all these things are put together. Secondly, entrance to nursing. We know that people who were coming to nursing earlier days were from maybe rural areas, maybe from lower socio-economic status, or people who were comfortable doing care-related responsibilities. But the trend is changing. We get students from across the country, all over the world. People are coming, whether they are from rural or urban areas. This change is happening. And we cannot say that it is only people from lower socioeconomic status who is entering the nursing profession. There are changes that are happening. Say with the competitive examinations where students have to compete to get a seat. And because of the job opportunities, we find different types of people from different locations, religion, culture are entering. And this change will be visible. And approaches to training. Now, we as teachers, we always say that, okay, students are not bold, or we say that students are not able to exercise their powers, they are very timid. So we have to be blamed for some of these ways of training, because it is the approaches to training that will also bring about some leadership abilities in the students. Having leadership means that we are able to also stand up for what is right, or to exercise our powers, or to communicate better. So maybe it is time to look inward and to think about various approaches to training. Should we go for something like a very rigid way of training where students have no say in matters relating to them, or there is no democratic way of doing things? So these are the things that we need to look at. Can we make our training more democratic, more participatory? Even if it is not democratic, say, can we make it more participatory so that students will come out openly without fear of the consequences? They participate, they try to negotiate, maybe they try to collaborate. This is what we need to think about improving autonomy. Also about leadership. How is our leadership? It depends on the leadership as to how a particular profession or how a particular department is having autonomy. Do you have internal democracy, or do you have distribution of powers with different people, or is it centered around one person? Is there a participative decision making that is happening? So these are all the things that we can think about having a relook and bring about changes in the future. So what promotes autonomy? It is decentralization, as I mentioned, and empowerment. See, you do decentralization, but nothing may come up. Empowerment is where you go after that particular situation, make people feel comfortable, encourage them to speak, interact, participate, and you are trying to build up that morale of the particular group so that they stand up for their rights, or they come out with better options or better programs. Communication. How good is the communication? How persuasive is the communication? How motivating it is? And what is our command? Huh? Sorry. And also about collaborative or teamwork. Now, when we say autonomy, it's all about the teams in which we work. Whether we are able to communicate persuasively with the team members. See, there is a doctor, there is a nurse, there is a physiotherapist, a pharmacist. Are we able to communicate and put forward our views? And then how much seriously people take our communication? Whether we are able to say, okay, this is my domain of work, I will do this for the best of the patient, I can do this, and how well we are collaborating for improvement of the situation. So this promotes autonomy because we need to also learn to work in teams. Many times our type of experiences with the students, we may find that students are not interested to attend the ward rounds, or they are to themselves. A nurse will only talk to another nurse, or a nursing student will only team up with another nursing student and not with some other professional. So when we have interdisciplinary teamwork, automatically communication will improve, collaboration will improve, and we will be able to exercise autonomy, and we will learn the ways that are required to have an autonomous way of functioning. Also, it is important that we have the leadership positions notified, having cadres. Is it only that we have cadre of a staff nurse, or do you have hierarchy there? And do you have designated functions in those places? So why I mentioned all this is because you would have heard about magnet hospital concept. Especially in the US, we have this what is known as magnet hospitals. Like some of the very specialized hospitals or recognized hospitals, where they are able to attract nurses or attract patients because they are very good. So these magnet hospitals have a different status in itself, and these magnet hospital nurses or different departments of work have these particular features. And it is said that magnet hospitals, the professionals have very good autonomy, and they continue to have autonomy, and they continue to attract people because it improves their work satisfaction. So if this is what determines autonomy. There are some problems also that you come across. We say we don't have autonomy in nursing or in a specific area of nursing. The problem could be that we don't have a proper line of authority. Who should report to whom? Who is coming under whom? Or what is the role of a particular person? And maybe we don't have proper channels of communication where you have official channels, every communication is written properly. We may not have job descriptions. Also, it is important that we have guidelines, standards, and the protocols. When we have the protocol, it means that you can follow the protocol, and then you don't have to depend on somebody to direct you to do this and that. For example, hypokalemia or any sort of problems that you come across. You don't need a doctor or another healthcare professional to guide you. When you already have a protocol, you make your decisions based on the protocol because you do the assessment of the patient and the patient's condition is so and so, and then you expect that hypokalemia is manageable by giving maybe potassium orally, or you say potassium IV. So this is possible, and it is good that we have protocols. But how many of our hospitals and setups have protocols is one question. And how then we talk about improving autonomy? Competencies I mentioned already. So if this is the autonomy, there are articles which say that to gain autonomous practice, nurses must be competent and should have courage to take charge in situations where they are responsible. So taking courage is something that needs to be trained, to be mentored, where all teachers and senior nurses have a role to play in mentoring the students so that they gain courage. Many times nurses may be competent, they may be having knowledge, but they may not be having a courage because they have only done what somebody else ordered. A ward in charge said, so I did this, or the teacher said to do this, so I did this. Not because I found some clinical evidence to say that a particular action was required. So that has to change. So we know that autonomy and nursing, the status is not very good, say, even in academics, administration, definitely not in the hospital practice. And clinical practice, what is the topic of today? That is the community practice. So in all, we are trying to improve the autonomy by having guidelines, maybe having competent people, maybe having standard operating procedures, protocols, etc. But the situation needs to improve a lot. And especially clinical practice, when we talk about, there are studies which say that decision making is part of nursing autonomy. So in which areas we can make decision, whether it is in the hospital or in the community setup or anywhere. We can make decisions on evaluation, diagnosis of the patient, prevention related aspects, the interventions what are required, communication, what to communicate to the patient. Nobody has to tell you. You should know what you have to speak and you have to continue to speak. Clinical information seeking. You are a nurse who's treating the patient and you have a doctor who has operated. Some information related to the clinical aspect you need to know. So you can't say that you don't know that. And that information has to come to you in order to help you exercise your autonomy, maybe in order to plan certain interventions. And setting of clinical priorities. Nobody should tell you that first you have to give oxygen, then you have to do this. You know from diagnosis, you have the nursing knowledge, you are a graduate. So you should know what has to be done and how it has to be done. And communication with healthcare professionals is another area where you can exercise your autonomy. So in this study by Kara V, what they did is they concluded that non-urgent decisions in that particular study, non-urgent decisions were 78% of the total, and that 60% of the nurses' intervention decisions were independent of medical order and related to the basic nursing care. Although it is not very bad, still there is a chance for improving because it is critical care and you have decisions which need to be taken urgently, and still we can improve these figures. So that is what this particular study said. Now, the topic of today is how different is community health nursing and autonomy status in community health nursing. And definitely, community health nursing has better autonomy compared to the hospital practice because it is all about world over, it is the same. So hospital to home or peripheral center are the places where community practice is done. And it could be from acute ward, people are moving to recovery or rehabilitation phase. There is a problem with availability of healthcare professionals. There may not be that many number available in the community health practice. Insurance sector influences about home care or about home visiting or community nursing, because they are also getting paid. Insurance is reimbursed and they cannot stay in the hospital for long. Also about resources, whether the community health nursing people who practice it, whether they have the finances, equipment, supplies, time. So these are the concerns. Clients and family preferences, and about independent practitioners. For example, home care practitioner, community health nursing practitioner, family nurse practitioner. There are many branches of nurse practitioners available even in the community setting. So what they do and where autonomy is possible. For example, home visiting is one important aspect of community health nursing practice, where the nurse is visiting the homes of the clients to provide the services. So when they provide the services, the prerequisites are kept in mind, like about availability of equipments and availability of healthcare professionals. All that is taken care of. Home care services, where visiting may be possible, school nursing services, industrial nursing services, or occupational health nursing services, rehabilitation services, parish nurse, or so many other categories what are available, what you see in the books or what you read in the journals. They are all part of community health nursing practice setting. So the setting is diverse, and here, as you see, there is more autonomy, because say in the school, the other people who are working are non-healthcare professionals. You are a school nurse, so you have school children who may come across the problem. You don't know what problem is going to come. So if you know how you handle each of those school problems, so you cannot be somebody who is just trained for a few months and work as a nurse. So the very difference in the community health nursing practice in many of the countries is that whether you are a community health nurse or you are a hospital nurse, you are definitely with the same qualification. You are with the same competency. A nurse who is working in the industry or a nurse who is working as a visiting nurse in US or UK or some countries like Canada, countries like this, they are all clearing the registered nurse examination. Nobody is underqualified. Nobody is underexperienced. So when it comes to competencies, you cannot say that somebody who is a home care nurse is a nurse who is not qualified or not an expert. So that is the level of competency they have. And then depending on the work situation, they learn, they adapt, and they are able to manage the situations. So that is why we find there is better acceptance for community health nurses. And see, the very reason why many people choose home visiting or community nursing is because the place where they stay itself, they can work, or they don't want to work in a very stressful situation like in the ICU for long hours, or they don't want to be under some team, some doctor and his order to be followed, some nurse, they have to work like that. They can work more independently. And that is the reason why people opt for community health services in those countries. So what happens where there is autonomy? So to learn about that, let us see how the home visit works, like how you read in the books, how the home visit works in those countries where community health nursing practice is well developed. So you find a client in the hospital. The client is staying in the hospital, cannot stay long, because like in India, they may not be able to stay in the hospital for long in the ICUs, because the insurance people will not reimburse the money. The hospital is at pressure of putting this patient out of the ICU or sending this person to the home or the nursing home. So critical phase is over, immediately the person is shifted. The person may be having IV injections or maybe on catheter, maybe wound dressing is required, oral antibiotics may be required, exercise may be required, monitoring may be required. but even then this person is shifted to the next care facility. It could be his home or it could be a neighborhood nursing home. It's because of the insurance that they are not staying in the hospital for long. So there is a pressure to discharge, as I mentioned. So there is a case management team which will take over the responsibility and shift this patient from the critical care unit to whichever is the preferred nursing home facility in the neighborhood of this client. And when the case management team is shifting this person to the place where this person is opted for, it could be near to the home, or it could be based on the money that they are able to pay, that it is decided. So all factors play an important role. So once that is happening, this home care agency is taking care of this patient. Suppose if this patient has decided that he is going home, or his people have decided he is going to be at home, with all these devices, home people may not be able to manage. So this home care agency, which is hired by the client, which is connected by the case management team, they identify the location, cost, client role, decision, etc. They allot the nurse. So this nurse may have another 5 or 6 places to visit every day, or maybe more than once a day, or maybe twice a week. So this visiting nurse is somebody who is connected to the home care agency, equally competent like that of a hospital nurse. So if there is a nurse who has to handle IV injections, catheter, wound dressing, BiPAP, lot of such life support equipments, if he or she has to handle, they need to be competent. So they are the registered nurses and they provide services. So in this context, definitely we can imagine that there is no second nurse, there is no doctor available, there is no lab technician available. There are not many people available near to the home of the patient, and this nurse is making the visit. So do you think the situation is very comfortable? If the nurse is a competent nurse and the nurse is somebody who is not confused, will be able to handle this situation. She will take up this responsibility, exercise our powers, and make decisions. That means this particular nurse is exercising his or her autonomy, because all the services that are required and order for the client is done. Suppose if they find that, if this nurse finds that this patient is unresponsive, or this person's pulse is this much, or blood pressure is this much, he or she will not have time to go on referring and all that. With experience, this nurse should be able to say whether the patient can be managed at home or be shifted to the home care agency or to the hospital. This lab investigations could be ordered by this nurse who is visiting. This nurse can also give emergency medicines. This nurse will be able to do lot of changes with regard to the treatment. This nurse can also do the assessment and inform the physician who is connected to this home care agency for advices. There could be 1 or 2 or few specialized people in the home care agency. If the nurse demands that some support is required, the home care agency will send the physician also home. So ultimately, when such a work situation is existing, automatically you take up your decision-making roles, you use your critical thinking abilities, and then you will be able to exercise the activities, and then you can say that you are enjoying that particular autonomy that is coming with the competency and with experience. So this is how home visiting works in most developed countries. So if you expect this sort of an autonomy for a nurse who is working in home care, what is helping? There should be similar standards of practice. The background of the nurse should be that every nurse is a registered nurse. You cannot have underqualified people or on the job trained people to be called as a registered nurse. And then everybody will say that this nurse is not having autonomy. You should be able to provide culture sensitive services. Your communication skills should be very good. See, it should not be somebody who is very much not communicating. You are assigned a patient, the patient is in the home, you are doing home visit daily or maybe weekly twice. You may have to communicate with the patient, you have to communicate with the family members, if at all there is a family member. They will ask you questions, you will have to give answers or solutions. So you cannot be somebody who is very rigid in your communication, and you should not be somebody who will take too much of time to establish a communication. This is a very essential skill that need to be there when you have to have autonomy and the power to exercise such decisions. And you should be having more of decision making power. You should not be confused, not asking or depending on somebody to make decisions. So this is one area where maybe we should think about posting students independently to different areas so that they are at least able to learn to manage themselves or their patients. Not always gathering together, and the team nursing approach is not going to improve autonomy too much. The nurse should be also able to solve problems, because you have autonomy, you have identified the problem, you will also try to solve the problems. You don't know how you solve the problem. Maybe you solve on your own, or you collaborate with a healthcare team or a nursing care agency and solve the problem. You need to coordinate. For example, you find the patient is unconscious when you visit the home. You need to coordinate with the ambulance, or you need to coordinate with the emergency team. Sometimes the patient may be confused, maybe not ready to go to the hospital or not ready to take the treatment. You should be able to persuade this person. So competencies are plenty, and these competencies will master you to lead to an practitioner with lot of autonomy. And you should also have good documentation abilities. You should know about the legal aspects related to your exercise of power and what activities you do. Entry should be done in the family folders or in the records of the client. And you should have a mastery over assessment. And when we say assessment, that is one area maybe many times the nurses fail, because maybe it is a practice that physical assessment and history taking has to be done, and the students should learn. Up to 4 years, they may be doing it when they write a care plan. When they don't write a care plan for that patient, they may not be doing the assessment well. They may not be doing the history collection. But every patient you take care, every client you come across, assessment is something that is directing all your actions. So you write a care plan without doing an assessment, it is an activity in vain. So therefore, I think as educators, we must focus our attention on ensuring that the students who pass out have very good skills in doing physical assessment and history collection. That will solve the problem in itself, and then they become competent to perform all other activities. And modernized procedures they should be familiar with, and training for the role is also very important in case the activity is not very clear. Moving on to the essentials. So when you say community nursing, it may be in a community clinic, it may be the home visit, or it could be in a health center, etc. So you must have all the equipments. You must have the supplies with you. Only then you can say that you are able to handle the situation, because you do not know what emergencies come. You cannot say, today I didn't bring my bag, or I don't have stock of supplies, or you cannot say that I don't have transport. So in most developed countries where community nursing practice is more autonomous, what they do is they are hired by the community care agency, and you cannot have one driver for one nurse. So the nurses who are working in the community practice are very independent. I have a car, you have a car, somebody else who is working as a nurse, or anybody has a car. You are given locations where the patients are requiring home visit or center visit. So you have the location, maybe Google Maps and other things. So you are given the address, you are supposed to reach that place. Nobody to escort you, nobody to take your supplies. So you have your bag or your car or your vehicle equipped with supplies and equipments, and you drive, you find the place, go and complete the tasks that are assigned to you. There may not be medical shops available. So your vehicle should have adequate supply of equipments. If required, you have to use it. So that's how real home visit will have more, the nurses who do the home visit will have autonomy. If required, anything can be done immediately. So why nurses choose to be in public health or home care or community health is because the status of working in a home care or public health is as same as working in the hospital. There is no status difference because both these categories are with registered nurse qualifications or cleared the particular examination. Pay is good because you are not working in the routine type of setting. You have risk involved, so your pay is good compared to others. You have less strain. For example, I'm especially talking about the stress of taking care of very seriously ill clients in the intensive care setups. It may be very stressful. We know that there are syndromes for nurses suffer from certain syndromes because they are working in the ICU every time. And the shifts are very long, and they may not, somebody who is not for all these may opt for a community health nursing type of service where autonomy is also good, stress is also less. But I cannot say that stress is less. If you're somebody who is competent, somebody who is communicative, somebody who is able to solve problems, you will feel that it is just another normal day. But if you are confused, if you are incompetent, if you are doubtful about your abilities, then you are not somebody who is suitable for this job, because you will find that small stress also very stressful. The scope for more independent practice is here, as I mentioned earlier about the home visit situations, what we come across in the developed countries, because you have everything. You have the supplies, you have equipment, you have the transport, you also have practice guidelines with you. According to the latest practice guidelines, you provide services to the client. There is also flexibility, like not a very rigid setup like that of an intensive care unit. So that is why many nurses opt for community health nursing service, especially because it is having more autonomy and the status is same. So that's about the other countries. What about India? How much of a cadre is there known as community health nurse or a public health nurse? Not many states have community health nurses or public health nurses. All we have is starting from the grassroots level. Even if we think about all those who are registering under the state nursing councils register auxiliary nurse, midwife or female health worker. They register LHVs or health assistants, and they register the registered nurses with GNM, BSc or any other qualification. So this is the category coming under the frame nursing. But we do not have very much of a cadre like public health nursing in most states. We have the auxiliary nurse midwives working in the sub-center, the LHVs working in the primary health center supervising the sub-centers. We have staff nurse vacancies and positions in the primary health center, maybe ranging from 1 to 3 maximum in most states. And then we have community health center, where again the designation is a staff nurse or a registered nurse, not as a community health nurse. So in fact, we cannot so much say that we have a cadre called public health nursing in most states. Many countries, many committees have advocated there was a reorientation of medical education, integration of health services to communities talked about in all our books and syllabus. Healthcare education, we are thinking of reforming. So where are we is one question that we need to answer. And we have different type of players who provide services: the public sector, the private and corporate sector, voluntary sector. Now, in the public sector, starting from sub-center, we have auxiliary nurse midwives. PHCs, we have staff nurses or registered nurses, and they may be coming in contact with little bit of community practice. In the voluntary sector, there are people, NGOs and other people who are providing services. We can say that in voluntary sector and in the public sector, in the grassroots level of a sub-center, some sort of community health nursing service in actual may be happening in terms of home visit or home-based services, or nurses taking a little more autonomy. So it's all at the grassroots level that we find. In voluntary sector, especially in the tribal areas and rural areas, we may have many voluntary agencies which are providing human services. Even the regular GNMs are working near equal to nurse practitioners or the doctors, because in those areas there are no healthcare personnel available, and these people may be on the foot providing services, or they may have smaller clinics or smaller hospitals run by them, where there are no doctors and others, but the simple nurse may be exercising autonomy and providing services. There may not be a legal provision for that, there may not be professional sanction for that, but there are people who are exercising autonomy, especially in the voluntary sector and in the public sector in the sub-center level by the auxiliary nurse midwife. So this is the Indian picture. Now we also have what is known as nurse practitioner. The community health nursing nurse practitioner, not as much as developed as the critical care nurse practitioners, although it is very important. So what is done? How can we change these practices? So we have what is known as the community health education, placement of different categories of people, subjects are there. How much we are talking about autonomy in practice and autonomy in community health nursing practice. We have theory, we have practicals, we have aspects done in the laboratories and in the fields. But how much the students who pass out are able to function with autonomy in the community setup. And when we say community setup, nobody can work in the community just by knowing some things what you do in the community health nursing practicals. Community health nursing is exercising all your knowledge and competencies, whatever you learn throughout your course of study. Anything that you have learned is applicable in community practice, be it nutrition or be it medical, surgical or foundations, everything you can practice. So what are the skills necessary? The skill focus should definitely be on history collection, because that is where we fail and we may not be able to function or meet the expectations. And we need to also think about improving our skills of assessments. Again, we have to think about improving the quality of the training, protocols, policies, procedures to be emphasized, identify the field practice areas so that students are able to function little bit with a little bit of independence and be able to fulfill the responsibilities and teachers have a great role to play. It's also important to have adequate supplies, equipments, because without having any resources, you send a nurse to the community and they are not able to do anything. That is also not favoring exercising autonomy and providing right type of services. Role of technology also has to be kept in mind, because we have e-health records, or we may have telenursing aspects, what could be incorporated to seek support whenever required, even if you are working in the community setup and you are able to exercise autonomy. It's also important that we have collaborations with different stakeholders so as to improve the autonomy. So when we talk about India and the community health nursing services, the scope is enormous, because there are problems: communicable, non-communicable diseases, nutrition-related problems, mother and child-related. We have mental health-related problems, elderly population on the rise, occupational problems. So problems are plenty. So are we ready to take up this challenge as community health nurses, or plainly as nurses, and in a way that is expected by the professionals, expected by the society, where your services are appreciated and you are independently able to exercise the responsibilities that are given to you? So when we say exercising this power or autonomy, it's also important that we need to focus our training and our support systems in a little modernized way. Say community bag. We know that there is a community bag that is used by the students, but sadly it is used during only the education. Thereafter, we do not know where it goes, whether any other nurse is using a community bag. And then we have auxiliary nurse midwives. My PhD was among the auxiliary nurse midwives. I have met so many of them, but they don't have a community bag. They have some equipments. When somebody is asking you to check BP, that day they take the BP apparatus. Or somebody wants medicines, they will carry that medicine in a plastic cover. Do we have a proper well-stocked bag, which is easy to carry, which can be maintained by them, available with them at all times, so that whenever required, this can be used as a resource in providing the services? That is something that is very important, because you don't have an equipment, you say you make people wait, it may not be accepted. So it's all about stereotypes. It's about your attitude or aptitude to learn, and about competencies. So this will lead a way in improving the competence. So where can we do this? In terms of preventive services, promotive services, curative and rehabilitative services, there is great scope. There are national policies which talk about the role of the nurse, national programs, and with the current programs, Ayushman Bharat and other newer programs, there are health and wellness clinics where nurses are entitled to provide services. We have the category known as middle-level health providers. But sadly, say middle-level healthcare providers are doing a good role. But then we claim that we have registered nurses, we have BScs, MScs, or GMMs, all of them passing out after proper testing by the universities on boards. And then to work in the health and wellness clinic or to work in the community, people feel nurses are incompetent. So they want these people who are selected to undergo a training to be called as middle-level health provider. So this is a question in itself. It is somebody questioning the authenticity of the training that we provide, because we are not giving a finished product. They want another bridge course to be fitting into the middle level health provider roles. But many of the middle level providers who have joined such positions, they have joined with the aptitude. Maybe they want to work independently, maybe the pay is good, or they want to be in their own communities. Whatever be the reason, many of them are doing good services. I have experience of talking to few of the middle level providers. What they say is that it's like a small clinic in a village. People keep coming for their health problems. They do the assessment. They talk to the PHC doctor. They provide medicines. They provide injections. They provide first aid. Some of them then require counseling. They do that. First aid, emergency medicines. Many things they are able to do. So maybe the middle level providers, if they do a very good job, then it is as equal to having the nurse practitioner at the community, because this is what is known as the nurse practitioner role. They are able to manage the health problems. It may not be complex health problems, but they are able to manage more or less problems that they come across in those setups. Then coming to the nurse practitioner role. So the nurse practitioner role is something that is very debatable, because in many developed countries, nurse practitioner roles have come up and they are doing good. However, many independent functions are there for nurse practitioners. There are also many dependent functions. They work under a particular doctor or a physician, and they may provide services for the patients of the physicians. What another doctor should have done, these are doing. They are paid less than the particular doctor if they had hired another doctor. But for the nursing cadre, when you see, the nurse practitioners have a better pay. Nurse practitioners are the ones who do daily rounds, do the assessment of the patients, order for investigations, check for the lab values, critical things, etc. So that means there is autonomy there. But independent nurse practitioners, there are nurse practitioner, critical care nurse practitioner, or pediatric nurse practitioner. They work under these physicians. But the community nurse practitioner may be having more autonomy compared to the the nurse practitioners, because they may be able to do more independent roles in the community. And they may be attached to a home care agency, or they may be attached to a nursing care agency. So ultimately, we know that there are plenty of health problems. There is a need for a lot of healthcare professionals, especially in the peripheral areas, rural areas, underdeveloped areas. We also know that there are plenty of nurses coming out of the nursing colleges. Job opportunities are there across the country, but many may not be willing to work in the community setup, although there is autonomy, because it is not structured like that of a hospital. So that could be the reason why many promising nurses who may want to exercise autonomy may not be getting into a community health nursing practice or the role. So if we think about having improvements in the restructuring in the way community health nursing service is offered, there could be many more people who may be ready to work. For example, in the health and wellness clinics, middle level providers, or if you have community health officers who are posted in the PHCs. So a BSc nurse or MSc nurse is also eligible. So in that case, there may be promising career for them, because autonomy is anyway there. So let us all work towards that, to have that sort of an autonomy, so that you feel good. The people who work are also having better job satisfaction, because there is better autonomy in the community health practice. So to summarize, we have to understand that responsibility and accountability are the key components of autonomy. We cannot be demanding that we want autonomy as a lip service, but we should be assuming responsibilities the fullest possible way with accountability. You are answerable to whatever you have done, why you have done, how you have done, everything. And we have to empower people to make decisions and feel that they are competent, because many times we may underestimate our abilities. Ensure that nursing care meets nursing standards, because it is ultimately the standard of services or the standard of care that matters, whether it is in the community or in the hospital. The clients are our ambassadors. The team workers are the ones who will feel good about you as a team member and appreciate the competency and the services that you deliver. So therefore, let us all work towards this so that we have more autonomy in the practice and autonomy in the community health nursing practice. Thank you so much. Any questions? I am open to answer.
There's no questions, madam, so far in the chat box. Thank you so much, madam. It was a very informative session. We talked about autonomy in community health nursing practices. So nurses chose to be practice in the community area. Before that, we must have the skill, knowledge, and we have to undergo certain training programs. So then only will become a more competent, and we have to work with the collaborative practices in community area. Thank you so much, madam. The session was very wonderful. Interactive session was there. And I thank. Yes, ma'am. I thank you, madam, on behalf of Power University, Power Institute of Nursing, and the principal, Dr. Ravindra H.N., his constant support. And thank you so much, madam. You accepted our invitation in your busy schedule. Thank you so much.
It was my pleasure. Thank you.
Thank you so much, ma'am.
Thank you once again.